for this lecture, and I'm very happy to be part of this Congress. So first of all, we have to say that although the report should be very simple, it's very central to the endoscopy practice because it facilitates the exchange of information about finding, therapy, clinical recommendation, adverse events, and performance of the procedure. A complete standardized endoscopic reporting system allows the offered service appropriate auditing and benchmarking, and through it's easily to be monitored over time. It offers the continuous quality assurance. At first, they were free text or unstructured text phrases, and with occasional photo documentation. However, this prevents the meaningful data extraction and was a barrier to quality assurance in endoscopy. But later on, comprehensive terminology were created and were in association with a coding system, and it was approved by the WHO. This allowed the description of every possible GI endoscopic term and created a platform to standardize language. And later on, minimal standard terminology was also created, okay? And this helped the unification of endoscopy reporting with and between countries. So how it should be done? Doctor? It should be electronic and integrated into the hospital patient record. Patient identifiers are very important because it facilitates the linkage to other data sources. Free text should be restricted to the minimum and should be based on structured data entry. Separate entry of data should be discouraged, should be done automatically. Endoscopy, double entry of data by the endoscopist or its associated person is discouraged. However, everything should be done automatically. Facilitate inclusion of information, so the histopathology of the detected lesion, patient satisfaction, adverse events, and surveillance recommendation. It should be friendly user, using a universally compatible format. Changes can be made easily and should contain key performance indicators. There are lots of requirements in the simple report that should be done. For the identification of the procedure, timing, procedure personnel, indication of the procedure. The safety checklist should be doing before starting your endoscopy, including patient identifiers, name, hospital number, date of birth. Any pre-endoscopic administration of medication should be recorded. There is no standard recommendation about antibiotic prophylaxis. Patients' comorbidities are very, very important. They're should be classified according to the American Association of Anesthesia Physical Status Classification to predict perioperative morbidity, mortality, and accommodate to adverse events. Informed consent, this should be recorded in the report and should be standardized for quality assurance. It should include the risks of the procedures and adverse events. And for that, the consent should be taken from patient with mental capacity. This is a legal requirement. As previously said, should inform the risks, procedure, benefits, and alternative, if there are alternatives. The endoscopy should be with adequate training and sufficient knowledge to be able to explain the procedure, its potential complication. And also, the report can be sent home for the patient to have enough time to read and assess. And if he's unable to take a decision, he should be coming back to the referred physician and to answer this question. Another checklist should be undertaken before completing and leaving the room. Should be reviewed, confirmed, and recording, including the number of histological samples, coding, labeling, doses of sedation, and will be seeing the other. First of all, the type of bowel preparation should be mentioned, and whether same day or split preparation. Also, the type and dose of sedation, and those who participated, whether the nursing staff or the anesthesiologist. Extent and completeness of examination is is crucially important because it's one of the quality assurance through reporting the landmarks with photo documentation. Also, those are the landmarks that should be mentioned in the upper, lower EOS and ERCP. Quality of bowel preparation and mucosal visualization are very important. They are indicator of determining the appropriate interval for examination, an indicator of quality and performance recognized and relevant for the evaluation of endoscopic practice. Poor bowel preparation will lead to inability to meet the pre-planned screening interval and prolonged cecal intubation, withdrawal time, and reduced polyp detection rate. Also, patient agitation or intolerance must be reported and arranged for next colonoscopy or endoscopy. Relevant findings must be reported, and they must be reported according to the standardized terminology and classification system. For example, if you have a polyp, you should mention the characteristic or number, size, and location. And if in doubt, you take a biopsy. For histological confirmation, should mention the location adequately. And depending on the nature of the finding, you should mention the scales to standardize the reporting findings. Also, therapeutic maneuvers must be mentioned. Endoscopic accessories or deploys must be mentioned, described in a specific fashion, manufacturer, device name, size. This is very important for follow-up procedure, for example, stent removal or migration. Medications used must be mentioned as epinephrine or India ink, carbon black, and the location the location and the total volume must be documented. Pertinent negatives must be specified. This is very important. Those are the standardized terminology and biopsy protocols in the upper GI lesions. Photo documentation is crucially important, but high-quality video endoscopy examination requires a standardized photo documentation of anatomic station. It should be performed carefully in tandem with mucosal visualization. The electronic image capture show variation in landmarks in bowel preparation, which can limit this photo documentation. Therefore, at least one represented photograph of the anatomic landmark should be considered. However, the European and the other societies refer to 8 in upper and lower GI endoscopies. And more photo documentation standards should be in risk factors for neoplasia, patient referring for endoscopic treatment, or any such suspicious abnormalities. And those are the standardized terminology in biopsy protocol, the upper and lower. Adverse events must be documented in any planned interventions, should be mentioned. Patient comfort should also be mentioned in the report. Diagnosis, which should depend on the history, laboratory, radiographies, new endoscopic findings, and should be performed using the standard terminology. As mentioned, endoscopic intervention should be mentioned with a clear statement, including the details of the biopsy specimens, labeling of the specimen, and whether it went to the pathology or not. Details of follow-up arrangement, the expected interval for the next examination should be mentioned in contemporary, according to the contemporary guidelines, and if delayed, should also be mentioned, and the reason for the delaying should also be mentioned in appropriate management following endoscopic, especially with antithrombotic therapy. Pathology should be mentioned, patient perception. Upon discharge, the patient should receive the report with full details as well as transmitted to the referring physician. There are lots of benefits of an electronic report. One of them is less time, unlimited number of images, database. You can do statistic analysis and a comparison, improving your endoscopy unit. the cost, although the cost at the beginning is very high, and you receive the cost after 5 years. Lately, you minimize very much the cost. Endoscopy facilities should implement policies to monitor.
Sorry, we are out of time.
Ensure the timeless of complete procedure reporting. And finally, there are lots of new techniques that shows you where are the pathologies. And thank you so much.